Hello, everyone. It is a great pleasure to see you again at the occasion of Heart-to-Heart Conversations, first in 2026. These conversations are broadcasted live over several platforms, of course, at PCR Online, which they are hosted at, but then also at Facebook, X, LinkedIn, and YouTube. It is important that you also know that these conversations are available as podcasts, so you can listen to the conversations whenever you want and however you want. What I would like to do now is introduce my interlocutor today, and that is Professor Javier Escaned from Madrid, Spain. It is a special edition for me because over the last 10 years, I have learned a lot from Professor Escaned, and I hope that we together can share some of your thoughts with everybody around. Professor Escaned, it is a great pleasure to welcome you here, and thank you for your time.
Thank you, Dejan. Thank you for having me and for your kind words.
So the topic today is basically something which I think is interesting to all of us, not only interventionalists, but cardiologists at large. So it is basically a question: what progress have we made in the treatment of chronic coronary artery disease over the last 20 years? And the way the two of us want to look at it is from the perspective of evidence, from the COURAGE trial to ischemia, but also from the perspective of the cath lab practitioners, with a closer look to improvements that have been made there in the cath lab in terms of intracoronary imaging and physiology. When we speak about these 20 years roughly from the publication of the COURAGE trial 2007 until ischemia 2020, and today we are in 2026, what seems to be the common theme of these two landmark trials is that the routine angiography-guided revascularization does not bring about any benefit in hard clinical endpoints, such as mortality of new MI, when compared with optimal medical therapy. The big elephant in the room, of course, is what kind of revascularization was actually tested. And I would like to ask you, Professor Escaned, what do you think about this?
Well, thank you very much for introducing this very important topic, and you are entirely right. I mean, if you, as you mentioned, we are going to be discussing this from the perspective or the interplay between clinical and interventional cardiology, paying a lot of attention to revascularization. Now, my first experience in the cath lab was 10 years after the birth of angioplasty in 1987. And at that time, there was a huge hype about PCI, as you can imagine. And we were convinced that we were saving lives when we were dilating a coronary artery and later when we were implanting a stent. That was our conviction. So you can imagine that I think that one of the strongest blows to the narcissism of the interventional cardiology was the arrival, particularly of the ischemia trial, because we all had the idea that the COURAGE trial probably was a study fraught by case selection, that was low-risk patients, etc. But the ischemia trial, of course, was circumventing this by, as you know, selecting patients that have moderate to severe ischemia. Now, once they does, we have to be cautious about this, and remember that, like any trial, there are many patients that we treat every day in the cath lab that were not included in the ischemia trial. I'm talking of patients that have left main coronary artery disease, patients that have the last remaining vessel, etc., etc. So there are many situations in chronic coronary disease that were not contemplated in the study. So the overall, I believe that the message has been very important, has made us much more humble, and it has reinforced the message that the benefit of PCI over medical treatment, proper medical treatment in patients with chronic coronary disease is very slim. And therefore, if you embark into PCI, it has to be the highest possible quality. That's the other aspect. You could also perhaps take the magnifying glass and have a look if the cases that were treated with interventional cardiology in the ischemia trial were treated according to a state-of-the-art PCI. That means, for example, use of intracoronary imaging that we will discuss later, and that we know nowadays that it saves lives, that it really improves outcomes. From the perspective of proper identification of the lesions that cause ischemia, we will talk about that, about physiology. So that is as a starting comment. I think that is what I will say about this very important trial.
There are, I think, 2 points which are worth mentioning and discussing on the ischemia trial, which gives us a sort of a segue to the other segments of this conversation. The first is that coronary artery disease, chronic coronary artery disease, does not stop at 3 years, which was roughly 3 to 4 years the primary endpoint of the ischemia trial. Well, there was no difference in terms of the combined endpoint. There was also no difference in mortality. So the chronicity of coronary artery disease goes way beyond those 3 years, and we've seen actually a difference in cardiovascular mortality in favor of revascularization from those data from the ischemia trial when we look longer than 5 years, at 6 or 7 years. So I think that the long-term follow-up will be crucial moving forward in trying to improve the care of chronic coronary artery disease. Number two, we did see already at the first report from a follow-up of 3 to 4 years, a difference in spontaneous myocardial infarctions. So we could definitely see that spontaneous myocardial infarctions seem to be lower in patients who are revascularized. Now, the question that I asked myself based on these 2 points is, number one, I do think that ischemia resembled courage as much as it said that for many patients with chronic coronary artery disease, we may have time before we intervene, and also that routine angiographic guidance may not be enough. On the other hand, if we are able to select those patients who will eventually get an MI, then of course revascularization would help without jeopardizing the patient, because of course we could see more peri-procedural MIs in those patients who are revascularized. Now, my question to you is, do you think that we could go beyond angiographic guidance and be better in selecting patients and selecting time points for revascularization?
Thank you. I mean, there are so many, interesting aspects in what you have commented, Dejan. We are now living times where we are exploring the concept of leave nothing behind, that is associated to the use of not deploying method stents and to do, for example, using drug-coated balloons or biodegradable scaffolds. And I always say, you always leave something behind. And what you leave behind is, as you mentioned rightly, atherosclerosis. So I think that there has been a conflict of the interventional cardiologists treating stenosis and not treating atherosclerosis. This is a big, big conflict. And from that perspective, it is outrageous that we have the possibility to witness, to gauge the quality of atheroma that we have in the patients that we intervene. And surely this has implications in the prognosis of the patient, the possibility of having a future cardiac event, etc. And we are not reporting this information. This information does not flow from the cath lab, as you mentioned, beyond angiography, information that you obtain with OCT, with IVUS. This information does not flow from the cath lab to the clinical cardiologists who are going to be looking to these patients. Now, for the second point that you mentioned, that is the difference in myocardial infarction in ischemia trial and the interventional or medical arms, I think that what you can see clearly is that from the perspective of the patient, from a statistical standpoint, both of them are myocardial infarctions. One of them is, a periprocedural myocardial infarction. The other one is a spontaneous myocardial infarction. Later on, statistically speaking, they balance and there is no difference. But from the perspective of the patient, there is a huge difference. There's a huge difference between having a myocardial infarction that probably is only noted in the raise in cardiac enzymes after PCI, perhaps nothing more than that, or the myocardial infarction that happens to the patient when he's having his holidays in Thailand, in an airport. Entirely different way of living it. And I think that these are again, something that we need to strive also to introduce both in interventional cardiology and in clinical cardiology, that are the importance of the patient view of the disease, the patient weight of the different outcomes, that is that is beyond the statistical, so to speak, way that we give to them in clinical trials.
Agree. So when we speak about improving revascularization, improving the quality of PCI, one of the first things we want to mention is the use of intracoronary imaging. Now, given what we said, that there is, let's say, a bar we need to jump over in order to be better than medical therapy, there are ways to improve PCI. Now, one of the questions is it imaging or not? Is there still a doubt in your mind that we have enough evidence that imaging can improve PCI? That's one part of the question. And then the second part of the question is, how do you think that evidence should be implemented? Does it concern all patients or selectively?
So, the starting point, of course, is that it is flabbergasting that in most cath labs in the world, the only imaging technique that is used is the only one that was available to Andreas Grunzig 50 years ago. While, in the same cath lab, people are doing
Which is angiography.
which is angiography. While in the same cath lab, people are doing structural heart interventions, and they're routinely using CT imaging, and they're measuring. Nobody will eyeball the size of the aortic annulus to place an aortic valve. That would be absolutely crazy. We will not admit that. But it's important to understand, that intracoronary imaging is as important as any other measurements that we are doing in structural heart disease. The only problem we have is that intracoronary imaging is no longer a novel technique. Many colleagues, imagine someone who started doing his practice in interventional cardiology 15 years ago, has routinely been attending meetings where they have live cases, sessions on intracoronary imaging. Is no longer something that it is there. And the debate on whether you need intracoronary imaging or not is something that cannot be resolved by attending these courses. We have all the evidence we need to say intracoronary imaging in complex PCI saves lives. I mean, this overwhelming now evidence in the drug-eluting stent era, and that is actually what supports the 1A recommendation by the clinical practice guidelines. So the point, perhaps, and that's something that we might elaborate a bit, Dejan, is why the community is not embarking into this. What are the obstacles? And how can we really improve this? Because we are indebted to our patients. We are indebted to offer them the best possible way of treating coronary artery disease. Remember, we go back to the ischemia trial. If you embark into revascularization as a way of treating stable coronary artery disease, you have to do it in the most exquisite and best way.
I agree. I mean, when you say that there is an abundant evidence which is convincing that intracoronary imaging improves outcomes when applied at least in patients undergoing complex PCI, then my question to you is Japan performing more complex PCI than Europe? Because if you look at the percentage, at the rate of imaging guidance for PCI in Japan, it's close to 90%, and in Europe, it's around 2 to 3 to 10%, mostly in the UK, 25 to 30% today. So what is the difference? The adoption rate is very heterogeneous globally, and it cannot be only due to reimbursement, because if you look at Germany and Japan, you would not think that there is huge difference in the reimbursement there, but there is a staggering difference in the application of intracoronary imaging. What are your thoughts on that?
You are absolutely right. Reimbursement is the typical subject. The typical subject. Suspect. Sorry, it is it's the typical, so to speak, cause that is put forward to is the scapegoat. Perfect term to justify why people are not using that. But remember, this is very easy to demonstrate these folks. under the same conditions of reimbursement. For example, in a country where you have reimbursement for IBUs, there will be centers that will be using it a lot and centers that will not be using it at all. And even within a single institution, you will have operators that they use it a lot and also operators that they don't use it a lot. So I personally believe that the first thing we have to be aware is that um, performing, for example, a left main PCI nowadays without IVUS is equivalent to sending a patient for surgery and having the patient back only with saphenous vein grafts. It's as simple as that. No clinical cardiologist will allow his patients, I believe, allow his patients being sent to coronary surgery to come back with saphenous vein grafts. He or she will be expecting that the patient is treated with arterial grafts. How is it possible that the same professional that is sending the patient with a left main stenosis for PCI is not demanding, not requesting that it is treated with the same standard of care, which we know that has exactly the same type of implications for the patients? These are the questions that we have to address. We have to really generate awareness among the community, that this is something that we really have to trust the data. We really have to modify our practice according to this overwhelming evidence that using intracoronary imaging complex PCI is important for our patients.
Yeah, so one of or two issues are here, I think, very interesting. One is the time issue. When you speak with people around the world, they will tell you that performing intracoronary imaging takes time. And I guess that's an issue of a changing PCI culture where, as you said, when you go to a surgeon, then arterial grafts are a standard of good care. And if we accept that intracoronary imaging guidance is a standard of good care for complex PCI for us, then we need to change the PCI culture to allow more time for it. On the other hand, education, knowing what are the key variables that you look at once you pass the IVUS catheter or an OCT catheter, knowing that will speed up and streamline the process as much as the AI will in the future as well. So I think that both accepting a PCI culture where intracoronary imaging becomes a standard of care, of quality of care, together with an education that allows for new generation of interventional cardiologists to be quick in interpretation and decision making, that together might increase the adoption. What are your thoughts on that?
Well, you're entirely right. I think, unfortunately, I believe that in terms of self-assessment, many clinical cardiologists are happy just to be able to complete the procedure without a myocardial infarction and the patient leaving the hospital alive. I mean that, in many occasions, this is all the feedback that the interventional cardiology has about the outcomes of performing the intervention. We have countless examples of that. And nowadays, with the tools that we have at our hand, stents, etc., a blood occlusion of the vessel, a serious complication occurs very seldom. You are an expert in bifurcations. Perhaps bifurcations generate lots of interest because it's one of the scenarios where you can really be in the situation of occluding a side branch. But out of that, in general speaking, you can perform a PCI that apparently runs smoothly, but still being suboptimal and triggering in the long-term events. So on one hand, there are ways of breaking this vicious circle. One of them is that once that the interventional cardiology has the opportunity to assess with intracoronary imaging the results in the intervention, will understand that in many occasions the results are suboptimal and there was a need for optimization. This is one of the aspects. The second one is that we have, as I say, a shift in culture where not only the interventional cardiology, but the clinical cardiologist is requesting that the patients that go to the cath lab are treated with the highest standards. And the highest standards imply, using routinely intracoronary imaging, physiology, all the very important tools that are endorsed, supported by clinical practice guidelines recommendations. But I think that it will be something that probably with the help of the new generation, I was recently visiting India and I was really impressed by seeing how very senior cardiologists were really uptaking, intracoronary imaging, all the very high standards. It's something that you can do at any age, at any degree of seniority in the cath lab. But still, I think that with the new generation, we have a new hope of bringing the quality of PCI at a higher level than it has been up to now.
Very good. Well, I would then try to shift gears and go towards a question of whether, by a careful patient selection, we may then overall achieve better outcomes in the long term, given that, as we said, these patients are chronic and will have to be followed up for long term. So seeing them in the cath lab is just one point in their long-term journey as having coronary artery disease, chronic coronary artery disease. So you recently designed and published a study called AID-angio, which I thought was very, very interesting because it kind of opened our minds towards a future where seeing them in the cath lab, we take the maximum information from the angiography and the available tools to assess epicardial and microvascular physiology. Can you tell us more about this study and why do you think that it might change the outlook and our practice, how we move forward to assessing coronary artery disease once we see the patient in the cath lab?
Yeah, thank you. That's AID-angio to me and to our team, was an eye-opening study. And basically, we wanted to know what happens in the patients that are sent to the cath lab with chronic coronary syndromes. I mean, what type of disease they have. And we look into this from the perspective of first angiography, which is, as I mentioned before, in many cath labs around the world, numerically speaking, perhaps in most cath labs around the world, is the technique of checking what happens in someone who has a chronic coronary syndrome, versus an algorithm that incorporated not only the angiogram, but also the use of pressure guide wires whenever you had stenosis that had intermediate severity, and also functional coronary testing, which basically implies measuring coronary flow reserve, microvascular resistance, and performing the acetylcholine testing to rule out the presence of vasomotor disorders. So the functional coronary testing, we can refer to this to INOCA testing. Now, what you can see in this study, and it was fascinating, is that out of the patients that come to our cath labs in Spain, angiography only gives you an answer of what happens in 32% of cases. And in these cases, you find severe stenosis that, without any doubt are causing ischemia. Now, if you apply the algorithm that I mentioned, that you find that actually you can increase enormously the diagnostic yield of invasive diagnosis. Okay, remember that the patient came to the cath lab, and I'm sure that the clinical cardiologist gauge, the fact that this is an invasive procedure, has certain risks, that became convinced that it was worth sending the patient to the cath lab. Now, I must say that the clinical cardiologists were right, because in 84% of these patients, you could find something. The only problem is that angiography only will provide you an answer in 32% of the cases. But as you can see, in the rest of the patients, up to 84% of them, there were either stenosis that were significant even when they were moderate angiographically speaking, or there were vasomotor disorders or structural disorders in the microcirculation. So you can imagine the enormous importance of this. This, by the way, is illustrating the iceberg picture that the European Society of Cardiology has brought in the latest edition of the chronic coronary syndromes guidelines, where they depict myocardial ischemia, chronic myocardial ischemia, as an iceberg, where only the tip above the sea level is, or the water level, is actually obstructive coronary artery disease. Most patients that have chronic coronary syndromes, angina, etc., have a component of non-obstructive ischemia that is caused by vasomotor disorders or by microvascular dysfunction. So, as I say, to us, it was a really important study. I can say that this algorithm was applied ad hoc. So it was at the time that the patient came to the cath lab, we continue. It only added 15 minutes more of studies, but you can see that it was changing really the perspective of treating the patients, because we reached a diagnosis.
Yeah, it's fascinating that, all the studies we've spoken about, the big landmark studies like courage and then later ischemia. Ischemia is contemporary, have not really utilized this knowledge. So, the patients would come, they would have chronic coronary artery disease, they would have angiographic stenosis, and they would have positive non-invasive testing. However, we would not know anything about the spasm, we would not know anything about the microvasculature, which has a meaning, for example, after revascularization. What we also did not know, we did not check whether the revascularization was optimal. If you perform physiology, if you measure FFR after stenting, in many patients, at least a quarter or 30%, you will find actually ischemic values to be there at the end of the procedure. So I think these are very important components. So when I see a study like AID-angio, it tells me basically, that if I may say so, that the progress we made over 20 years is to recognize what we are missing. And I think that imaging and physiology basically, I think, shows us a way. They show us a way how to approach the patients and maybe do the things that we have missed out on doing in the past 20 years on a more structured and systematic basis. That could be the future we are looking towards, where we are going to know much better the phenotype of the coronary artery disease of our patients. And when we embark on PCI, we would have options like drug-coated balloons or stenting, which, when chosen, will then be imaging guided, which could then overall change the outcomes of our approaches to the patients with coronary artery disease.
Absolutely, you're entirely right, and let's also keep in mind that in patients with chronic coronary syndromes, the main reason we perform this treatment is to improve symptoms, but our results are disappointing. I mean, between 20 and 40% of patients in whom we performed PCI continue having angina. Remember that. These are the figures. Huge. So that means that PCI is a suboptimal tool to treat angina. And the reason is, as you mentioned, because in many occasions, the result of the intervention that you performed was suboptimal in relieving ischemia. Because in other cases, the cause of ischemia was different to obstructive disease. So this is one of the important aspects, as you mentioned, and believe me, we use a lot of physiology to optimize our PCI, and you cannot imagine how many occasions, even when we had a good angiographic result, we identified that actually we were leaving behind, now in the right sense, a lot of flow limiting disease. And then you have the other component of people that have a miserable life because they never get diagnosed of having something whose life can be changed dramatically by giving calcium channel blockers or treatment that modifies a vasomotor disorder. It is really urgent to implement these techniques in practice, I believe.
Yes, definitely. I mean, positive stress testing doesn't tell us a lot about the epicardium. You could have moderate stenosis, and the positive testing could be because of microvasculature. Dr. Divaca Pereira, he did a great study showing that basically all those seemingly false positive non-invasive stress tests could be attributed to a problem in coronary microcirculation if there was nothing at the epicardial level. So I think that that's very important moving forward. Wrapping this up, just a final thought from my side. We both have a liking for reading also beyond cardiology. And I would say that, Socrates once said that, the smartest man is the one who realizes what he does not know. So I guess over the 20 years, if you look at courage and ischemia, it could be that a lot of progress was made showing us what is it that we do not know. Maybe we are not as efficient in selecting patients properly who will benefit from revascularization. And maybe imaging and physiology can help us, and increased use of imaging and physiology could help us get better in recognizing which patient to treat with a PCI, when during the course of their chronic disease, and of course how, given the options of imaging guidance. But I give a last word to you, please. What is it, the progress that we made, and what awaits us treating chronic coronary disease moving forward?
I think, it's well, now that you mentioned, philosophy, I think that Something that we need to understand, and I will quote, probably Thomas Kuhn, who, as you know, is the philosopher of science who coined the term paradigm in science. And he described very much how science progresses. And in a way, his reflection says, listen, at the end of the day, the progress of science is something that is linked to us as individuals, as a society. It cannot be separated from culture. There is a culture about this. And we have to understand that when someone is refusing from the very beginning to use IBUs, for example, here in Madrid, it's probably different to the attitude that someone has in Japan. So the culture, when you were saying before, why in Japan do they use a lot of IBUs and why in France, for example, they use very few? These cultural aspects are important. I think that we need to make an exercise to circumvent these obstacles that are derived from our psychological build-up, so to speak, and try to really refocus and bring to our practice all the evidence, which is intangible, but we know that is real, that can help to our patients become more humble and become more integrative in something that painstakingly, the knowledge that painstakingly has been obtained in understanding what is the disease and how to treat it.
Thank you very much. So we keep working towards the benefit of our patients with chronic coronary artery disease. Thank you very much, Professor Escaned. It was a pleasure.
Thank you, Professor.